Hello and welcome to The Art of Aging, which is part of the Abundant Aging podcast series from United Church Homes. On this show, we look at what it means to age in America and in other places around the world with positive and empowering conversations that challenge, encourage, and inspire everyone, everywhere to age with abundance. Today, we're going to be talking about the world of the hospital and how to navigate the world of the hospital. And it's something that more likely than not, you're going to face in your future, at least with a loved one. And we've got an expert to talk about that today, Dr. Monique Nugent. We're pleased to welcome her to the show. And just to tell you a little bit about Monique, she is a practicing hospitalist and a physician leader at a large independent health system in the Boston suburbs. She completed both medical school and residency in internal medicine at Loma Linda University Medical Center. And after completing her medical training, Monique obtained her master's degree in public health while a fellow in the Commonwealth Fund Fellowship in Minority Health Policy at Harvard University. Dr. Nugent has shaped her career to include leadership and advocacy alongside her clinical practice. As a physician, she advocates for every patient in working to make healthcare equitable, safe, and high quality. As a parent of 3 children, Dr. Nugent and her husband live in the Boston area, and she enjoys exploring New England and collecting cookbooks. She also loves to travel and visit art museums, mainly when she can talk her daughters into accompanying her. And I have the same issue on my end. Dr. Monique, welcome.
Thank you so much for having me. I'm looking forward to our conversation.
I am too. Yeah. And just a reminder that this podcast series is sponsored by United Church Homes, Ruth Frost Parker Center for Abundant Aging. To learn more about the center, including our annual symposium in October, visit unitedchurchhomes.org/Parker-Center. So, Monique, I got to ask you, this is a neat area of study. As a doctor, you could be doing a lot of different things, getting into a lot of different specialties. What got you so passionate about the world of hospitalization and how patients should be navigating it?
Yeah. So when you finish residency, you can specialize further. And, around your third year, everyone's kind of figuring out what they want to do. And I just really enjoyed hospital-based care. So for a while, I thought about going into critical care. But I had a really great mentor who said to me, when you pick your career in medicine, pick something you can A, do forever, and B, feel like you could have the biggest impact. And this is where I fell into hospital medicine, really focusing on making sure that the people who come into hospitals have a better experience, have a safer experience, have a more equitable experience. And as I've gone through my career, I've been doing this for about 15 years now in hospital-based care. As I've gone through my career, I've noticed the same patterns over and over and over. What is the saying? There's like everything old is new, or as something new is old, something like that.
Yeah.
I train on the West Coast. I currently practice on the East Coast. I've been in VA hospitals, academic centers, community hospitals, private hospitals. And it's the same exact experience because our system really is kind of built the same across the country. And people are coming into a hospital not realizing that it's a system within a system. And oftentimes their frustrations are not new. Several people have had those same frustrations. And there's a whole science and study around improving the experience and safety in hospitals. And I jokingly say the hospital is the healthcare DMV. Like everybody's going to show up there at some point in time, right? You're like, everyone's going to come by. Whether you're excited to have a child, excited because you decided to replace a joint, or you didn't have a choice because you had an illness or injury that was unexpected. We're all going to somehow come through the doors of a hospital. And I want to prepare people for that experience.
Yeah, and that's describing it as the DMV, and God bless the people that do work at the DMV, but it's not a very, the trope is it's not a very well-designed experience. People don't look forward to going to the DMV.
Exactly.
And so is that the job of a hospitalist? Is a hospitalist really to look at all the different systems that are present and the ins and outs and the operations of a hospital and see if they can improve it? Is that the idea?
So a hospitalist is either like an internist or a family practice physician who just sees acutely hospitalized patients. So I don't have a clinic that I go to. You can't make an appointment to see me. Uh, when you come into the hospital through the emergency department, if you're too sick to leave, you don't need the ICU. You're going to see somebody like me, a hospitalist. Granted, if you're over the age 18, right? But this form of practice of realizing that the things that go on in a hospital and the care for acutely sick patients is really kind of unique has spread across a lot of specialties. So you'll find pediatric hospitalists, right? Pediatricians who care for patients who are only in the hospital. You have laborists who are obstetricians who just help women delivering. You have acute care surgeons who are surgeons who see the things that come in through the emergency department or the things that are happening on the floor, and they're caring for their patients, in the hospital, rather than some other surgeons who you make an appointment and say like, oh, okay, I would like to talk about having this removed. I was sent by my oncologist, things like that. Because, the things that go on in hospitals are constantly changing, fast paced. Acute illness is very different from your chronic type illness, or an acute exacerbation of a chronic illness is a different experience and presentation and a different way that we treat it. So a hospitalist is really a physician who's going to take care of adults who are acutely hospitalized, who are not in the ICU. If you're in the ICU, you'll be seen by an intensivist. I've gone and done a little bit more study. You've mentioned getting my MPH and kind of focusing my career on the improvement of the experience for both the physicians and for other providers who care for patients, and also the patients in the hospital.
Yeah. I mean, it strikes me that the role of the hospital in the healthcare system, it just seems to be just this centralized hub. I mean, when I look at, look at Medicare spending.
Mm-hmm.
The biggest proportion of Medicare spending outside of the transfers of money to Medicare Advantage plans is hospitalization. When we think about all the incentives in the healthcare system right now, everyone just keeps pointing at the hospital, and the most effective measure of at least in managed care programs that I've seen is lowered hospitalization and lowered rehospitalization rates. Right? Why do you think? I mean, is it why do hospitals just seem to consume so much money?
Hospital-based care is very expensive because, like, people jokingly say, like, if you take a Tylenol in the hospital, right, that's an $18 Tylenol versus you buy a bottle for like $4.99 at CVS, right? But let's break down kind of like why is this an $18 Tylenol? Well, the hospital has to pay for the building, pay for the energy to run that building, the water. They have to pay the nurse. They are paying the provider who prescribed it, and their insurance, and then the hospital has their own insurance. And when you are at home, you can like put some Tylenol in your hand. I want to take 3, not 2, and you take them, put it back. Can't do that in the hospital, right? So it has to be like either individualized, or the nurse is going to use gloves and she's going to put them in a cup. Like the care in the hospital is a lot more cumbersome than what goes on at home. And so it really is very much an apples or oranges thing to when people compare the two. But also, like, they're unfortunately beholden to businesses. They're a business. They have contracts, right? Like, you can buy a CVS if it's on sale, but if the Tylenol's on BOGO 2 for 1, you decide to do that. No, hospitals have contracts with insurers. They have contracts with pharmacies. They've got contracts with different people who come in and supply medical equipment. And then also, like, at home, you're caring for yourself. So you know the things that you need. A hospital has to be ready to care for everybody who walks in the door.
Yeah, right.
Right. And so there's a lot of things that, are available for everybody that may not be used all the time. And then remember, like, again, cooking for 400, 300 hospitalized patients who require, an additional like 200 different types of diets, and then different types of textures. So like just the level of care and the acuity that goes on in a hospital is part of the reason why it's expensive. The other part of the reason why it's expensive is because healthcare is expensive in this country. We have unfortunately built a healthcare system where pharmaceuticals are expensive, and procedures are, more reimbursed than not getting a procedure. So it's a combination of the reality of what a hospital has to do to deliver care for a patient and the reality of the healthcare system that we have built in this nation.
Yeah, yeah. And I just think about, I mean, you talked about planned hospitalizations, and those are predictable, but it really just, I never heard it explained that way, that they don't know what's happening on any given day, right? Anybody could be walking through that door. And I guess for people, there's such this storied, the hospital, I guess, in everyone's mind is just the place that's always open. It's the place where you can always go for healthcare, right? I mean, it's always, when you have an emergency, the instinct is to go to the hospital, which adds to that. And but there's more of a trend towards, I mean, how has urgent care evolved as a part of that? Do you see more hospitals buying urgent care clinics, or having those relationships so that they can steer some of that traffic to places that may deserve more of that lower acuity setting? Or
Can I circle back to an earlier statement that you made about the hospital
yeah,
always being open and the place that we go when we need help? I
yeah,
think the other thing to really think about is the hospital's become a big safety net socially. It is also socially always a place that is open. It is also socially always a place that can solve problems. Social workers are always available in the hospital. People who may lack housing, may lack food. And then, with older people, sometimes you get into the situation where like being at home isn't safe, but there's no setup for you to go to a place yet. So the hospital becomes this interim where you and your family are actively seeking medical care, but also trying to figure out the next social steps. Right. And so there is a cost to the social supports that the hospital provides for society as well.
well, it becomes a habit, doesn't it? If you go to the hospital once because just, it's an instinct to go to the hospital, and navigating the hospital can be challenging maybe the first time you go in.
Hmm.
But then the next time, and the time after that, it's kind of like, I know this. I know what's going to happen. I
And the
can
system
spend that
knows you,
time.
right? The
Yeah,
system gets
right.
to know you. And I tell people that, like, if you do have to go to a hospital again, try to go to a place that knows you, because the system builds a story about you. And that story adds to your safety, right? Because it has all of the meds you've taken and things like that. And it is a point, excuse me, there sometimes does get to a point in people's medical illnesses where you will see this repeated hospital stays over and over. Um, Oftentimes those people are referred to in the system as high utilizers. And
Mhm.
there's a ton of attempts to try and break those cycles. They sometimes get assigned to like specific case managers or social workers. Hospitals have ways of tagging them. ACOs, or accountable care organizations, have ways of tagging those patients and trying to get them more resources into the home. And the truth is, like, a lot of the times when you look at these situations, it may boil down to like one of a few things. One, it may be that an illness is very actively changing and progressing, and they do need that active support, right? There are times in an illness, particularly as maybe someone is progressing and getting worse, where like things change a little bit more rapidly, or they change more than someone would expect, right? So they need that little bit of extra assistance. But then there's a lot of the times there's some kind of social issue that's going on that doesn't allow the person to really thrive outside of the hospital. And they're coming to the hospital looking for that support.
Right. Yeah.
And so how do we intervene? And that's really the question I think that this country hasn't solved is where do we say we're going to put more resources into social things to prevent medical need, versus the fact that we know if we put it into the medical need box, it creates a bill and somebody gets paid and we know who's responsible for X, Y, and Z. But in the social box, it's really a lot more nebulous. And I don't think we've had that conversation as a nation yet.
Yeah, it's and this isn't. I don't necessarily think these are things that are taught in medical school, right? I mean, you've got people coming again and again to the hospital. I mean, I know one of our team, terrific person, has a story about a gentleman that went into the hospital again and again and again for exhaustion, and it turns out his wife has dementia, and he didn't want anybody to know because if they
Mm,
knew, then maybe they would take her away from him. These are crazy things to unpack. But I just get the impression that hospitals just don't have the time to be that advocate, to be that social worker. The stereotype is you're in, and then you have to make a decision about how to transition someone in care, and then sort of dump the person onto the next site of care. They send the person home. I mean, you get into the hospital, you get stabilized, and then the problem follows on to the next site in care. I mean, is that a terrible way to think about things?
So you're right. In medical schools, I think medical schools are better about it now, about talking about the social determinants of health. But I still think we need to remember that they are medical schools. Like, in the end, you're trying to train a medical professional. You're trying to train someone who's going to have a certain amount of medical knowledge to be able to create safe medical plans that are effective for people. Medicine is not practiced in a silo. I tell my teams and my patients this all the time. It is impossible for me as your physician to keep up with everything that goes on. I do not know all the changes in Medicare and Medicaid. There's no way I know which assisted living shut down and which one built a new wing. It's impossible for me to know. What I need to be knowing is cell counts and the new antibiotics that are coming out and the things that are safe, so I can create that medical plan. How hospitals are supported by social workers, case managers, the community. And those are professionals themselves who have a ton of training and have the ability to get out there and do this work. But do we as a nation value that work, right? Is that what our insurance agencies will remunerate the hospital for? Or will they pay the hospital for a hip replacement? Like, we have not yet decided what is more valuable, keeping somebody out of the hospital or paying for that person every time they come into the hospital to solve a problem, right? We do not have a healthcare system in this country. We have a sick maintenance system in this country, right? If we truly had a healthcare system, all the things that you and I are talking about would be the highest priority. Making sure people are safe in their home, that they're fed, that they're not lonely. Loneliness is a big problem, particularly for our elders. And then when somebody needs help, getting the resources to make these transitions smooth and quickly. Because you're 100% right. Like, back in the 70s, 80s, 90s, you used to go to the hospital and get better. And I say it, and I've said it in my book, the hospital is no longer a place to get better. It's a place where you get your care and you move on to the next stage so that you can recuperate and you can get the things you need to get better. Insurers do not pay for you to be in the hospital. Like, I will get a phone call from an insurance agency if they feel the patient's been in the hospital for a prolonged amount of time. And I have to justify to them as to what am I doing and why does this require hospitalization? Also, when someone comes into the hospital, I often have to ask, am I going to make a change for this person's care if I admit them to the hospital? Or is this care that does not need to happen in the hospital, right? So shifting where care takes place helps for lots of reasons, but also can make people feel, like you were saying, they're kind of pushed out, dumped, because the problem solving hasn't really occurred. And a lot of the times, the true problem may not be just medical. The true problem may be more of their social supports, goals of care, long-term plans. And those are not things that I can prescribe, right? Those are things that are conversations that take time to solve.
Yeah. No, I mean, there's so much there. I mean, it's almost like, unfortunately, and people really only notice things when they go wrong, right? I mean, when things go right, people don't notice them at all. But if things go wrong, that's when people sort of, point at things. So it's kind of like you can't win, right?
Yeah. I mean, I have a friend who is an organizational engineer, and he says we don't have a broken healthcare system. Our healthcare system produces the results it is created for, and it is created to keep these problems going, because we have not decided that they're true problems yet.
Oh, goodness. Well, let's shift and talk about really what patients can do here, because, if you're facing a planned hospitalization, if you're in the hospital, What are some best practices for patients to know as they navigate themselves when they're in the hospital, and how can they maybe be good advocates for themselves in those transitions of care?
Yeah. So people often ask me if you can prepare for a hospital stay. Outside of pregnant people who pack a bag and their snacks, most of us don't think of ourselves as being ready for a hospital stay. Even if you have a plan, like let's say you're going in for chemo, that those type of things, though planned, are also not like 100% exciting, right? And so it's all about information and getting that information to the care team because more information helps assure safety, right? If you know your medications or know where to get a list of medications, this is 2024. You don't have to memorize things anymore. Like your primary care doctor likely has an app associated with their health system. CVS or Walgreens can you can call and get the list of medicines that you're taking if that's where you consistently get your prescriptions for, right? But if you can get the information of what medicines you take, that is going to help a great deal. There's a process in a hospital stay called a medication reconciliation. And that's when you get all of the medicines the patient is taking and you look at them and you say, okay, and these are the medicines I want them to take. And then you say where they line up. You do that on admission. Why is that important? Because likely I'm going to be prescribing you new medicines. You want to make sure things are not interacting, that I'm not duplicating, that I'm not going to cause a poor side effect because it's an unexpected thing that you were taking a medicine I didn't know about. Or you may be on a blood thinner. We need to plan for a surgery, right? So all of those things help to create a safe medical plan. And that process goes on throughout your hospital stay. If you go in and out of the ICU, in and out of the operating room, and then it occurs again when you leave the hospital, the doctor is going to say, okay, these are all the medicines you're taking in the hospital. These are all the medicines you were taking beforehand. Now these are the ones I want you to take, right? And again, what is that?
Yeah,
That is
is that what
safety.
polypharmacy is? Is that what polypharmacy is all about, or am I mistaken?
Yes, polypharmacy is when you're taking a lot of medicines and they start interacting with each other. And so you're
and what about nutritionals? Like if I'm taking and nutritionals are kind of crazy in this country too, right?
Yeah.
I could go on my front lawn and take grass clippings and sell them as nutritionals, right?
Yeah. So you do want to tell all of the things that you're taking, including nutritional supplements, because some supplements are known to have certain side effects and interactions with prescribed medications, right? And so you do want to tell people that. And it's all about safety. And then again, also talking about like if you see a specialist, making sure that the hospitalist is going to know who your specialist is and how to contact that person. Because the last thing that we want to do is to mess up a long-term plan that you may have for care that's going on, right? We don't want to like totally recreate the wheel and then like whatever your cardiologist was doing is now like bunk and has to be redone. That's not what we want to do. We want continuity of care. And we alluded to it earlier about the information that a system has about you, right? We do not have a nationalized healthcare system. I'm sorry, medical record in this country, right? The VA has a medical record that is available through all VAs across the nation, but not every hospital's medical record talks to the other hospital's medical record, even if they use the same vendor. Like Epic is a big medical record that is used. Not every Epic system talks to the other Epic system across the nation, right?
We need interoperability.
We do.
Which I've been hearing at conferences for the last 20 years.
And so when you show up at a new hospital, like I understand you may be on vacation and it's totally not avoidable, but if you normally go to the hospital on Route 9 and then you're like, today I'm going to try a hospital on Route 31, Route 31 may not have any information on you, and now they're building your story from scratch. And what I said earlier, information is safety, right? Mm-hmm. Having more information, the institution can tell your story. Because each time another provider logs in and writes a note, prescribes a medicine, gets a lab, that story becomes more and more flush, right? And so there is there is benefit to going to a system that knows you.
Right. Well, I love that. I love that phrase, information is safety, because it may seem frustrating to patients to say, okay, I do need to bring my medication list. I do need to tell them about nutritionals. I do need to have a list of the doctors that I'm taking, or what have you. But when you start unpacking the reasons why, it's really just all about protecting yourself.
Yes. When
I'm
I,
also thinking,
yeah,
sorry.
I'm so sorry. When I was writing my book, I reached out to a lot of my friends who are hospital-based physicians. I said, what is the thing you want patients to know that like I can get across in the book? And almost every emergency medicine physician, a friend of mine, said, please, can you tell people there's no such thing as the record? Like, like you can't just look at me and say like it's in my record. Like you have to participate and tell me something, because I may not know you. Like if you're here a lot, that's great, but like we may not know anything about you. And so I was surprised that when I have these conversations, a lot of people say like, really? But real, and I'm like, yeah, a lot of that information becomes proprietary in a way. You have to sign permission for them to send it. There's
Yeah, you
also
see, everyone saw that episode of Seinfeld where Elaine went to the doctor and was mean to the doctor, and then she tried another doctor, and the doctor looked at something in the chart and said, "Oh," because all the doctors talked to each other and they were like firing
I
against
have
her. That
not
does
seen
not
that
happen.
episode. I have to check
It's a
that
great. I
out.
know. I'm sorry. I'm risking it here on the podcast. Sorry, listeners. But if you know it, you know it. But yeah, there is this kind of myth of just like that one record to rule them all. But it's not. It's just not there. The other thing that's crossing my mind right now is, and first of all, what is the name of your book and where can people get it?
Oh, yes. Thank you. So the name of the book is Prescription for Admission. It's a doctor's guide to navigating the hospital, advocating for yourself, and having a better hospitalization. It's one of those books with like a semicolon and a lot of words. So you can just stick in Prescription for Admission in Barnes and Nobles or Amazon or anywhere you buy books online, and you can find it. It's really meant to be a guide for patients. It's not written for physicians. It's written for people to use for them and their loved ones. So it's got places for you to fill out your thoughts and practice writing your medical record and practice writing your
Oh, that's
medication lists
terrific.
and all of that stuff. So please check it out. And a lot of this conversation, basically all this conversation will be in there, except for the more juicy parts we talk about healthcare and theory and stuff like that.
I
That'll
love
be a
that you're
different
doing the
book.
work for people here. I mean, you're giving them the workbook, you're giving them things to fill out, you're giving them a checklist. So I can just see people bringing Prescription for Admission around them everywhere, because it's got all that person, it's a place to store all that necessary information.
Yeah, I really want people to have the information, because hospital stays are not easy. Like even a good hospital stay, even when people say like everything went well, they're still leaving with new medicines or new providers. They were still sick and in pain, and someone had to come and advocate for them. Like even when things go well, it's not an easy experience. So I want to give people the tools, because strangely enough, I really love hospitals. I think they do amazing work, and I want to be a part of making sure that we're delivering what we say we should be, which is good care that's safe, that's equitable, that's caring, that's non-judgmental. Because I think hospitals have a big role to play in our country's healthcare.
Yeah, but I want to get on to something that's important, around the discharge process.
Yeah.
And the discharge process, just in my personal observation, can be a very frustrating experience for patients and especially for their family caregivers. Somebody may expect to go to nursing care, but they're sent home, and there's also the language issue there. I mean, there's a lot of information that kind of gets pushed at discharge, and it seems, the stories I hear, it's rushed. I can't understand what people are talking about. I mean, how can you be a good advocate for your loved one or for yourself, during that point of discharge?
So all discharges should start being planned for on admission. And I know some people bristle when they hear that, but you should be thinking about, when you or your loved one comes into the hospital, you should be thinking about what do I want to happen and where do I want to go when I'm leaving here? Because it's a conversation that should occur throughout your hospital stay. If one day before you leave the hospital, suddenly lots of decisions are being made, it's going to be rushed. You're going to be unhappy. You may not get the things you need. Things will be missed, and no one's going to be happy, right? Like, case managers and providers don't like when we feel like we're pushing people out either, because then on our end, everyone is scrambling to get things done, you know? So start thinking about that on the day that you're admitted. The day someone says, okay, you need to come in the hospital, we got to start thinking about, where do we want to go when we leave? What do we need for a successful discharge? The key, in addition to having the conversation throughout, is to have another set of eyes and ears. If you have a care plan partner, right? Who is your care plan partner? It's the person in your life who helps you with your medical decision making, someone who maybe takes you to doctor's appointments, and really helps you navigate your healthcare, right? The person who's going to know what is necessary for you to have a successful discharge. That's your care plan partner. For most people, it's also their like healthcare proxy, the person who they would sign to say, like, if I can't make decisions for myself, this person should be able to do that or is able to do that for me. But it doesn't have to be, right? If it's your daughter, if it's your neighbor, if it's your spouse, whoever it is. But if you have another set of eyes and ears, because it's not only are you like, you're either like excited to leave or frustrated that you're leaving, right? So like you're not fully hearing everything, but someone else also knows what it takes for you to be successful. Like, everything is a team effort for healthcare, both in the hospital and out the hospital, right? And I hear it and I see it all the time where like someone will say, particularly some of our elders, I'm ready to go home. I don't want to go to rehab. I'm like, okay, can you be safe in your home? Oh yeah, I'm perfectly safe in the home. I only have like 2-3 stairs to get to my front door. Oh, okay. And then their daughter will say, yeah, but you got like 18 stairs to get to your bedroom. Like, oh,
That's the thing. We see these patterns where I think in at least the research I've looked at is most hospital readmissions, I think like a good number of them happen within just a day or two of getting home. I mean, people will get out of the car and trip on the front porch. I mean, it may be tough for a lot of patients to say, look, I really want to go home. I don't want to go to skilled nursing, but they know in the back of their head that they don't have enough food in the house. They don't have a plan.
That's the hard part. You've been hospitalized for however many days. You're right. Is there food in the house again? Who's going to take me to pick up all the new medications that I had? Who's going to do a medication reconciliation with me in my house? Because the visiting nurse is going to come the next day or a day after, and you still want to.
Or home health could be days before home health comes in, right?
And so it does take a team effort to be successful for discharges, because it's not just are people medically ready to go, right? It's, are people safe to go? And this is the conversation I have with people all the time, because there is unfortunately going to be a feeling that I am not ready a lot of the times, right? Like I said earlier, the hospital is not a place where people get better anymore, right? Rehabilitation, getting better, feeling like yourself will occur outside of the hospital. Even if you were excited to go to the hospital and have a baby, you're walking out with this new baby that's crying and you got to figure out life and you're still in pain. And now you're going to start breastfeeding. Like, you're not like those people are not excitedly, perfectly comfortable either. Right. But are you safe? And that's the question I ask my patients when they get discharged. When I'm talking about discharge, do you have everything in your home to feel safe?
But people feel embarrassed about that, though. I mean, people tend to feel. I mean, I've seen people getting phone calls, from the hospital, and they're just checking up on you. Do you have everything you need? Yeah, I have what I need, and they have none of those things. But people feel there seems to be this relationship with doctors. I mean, doctors are so well respected, and you guys have your own language, and sort of admitting to your doctor that that I'm embarrassed because I don't have these things. I'm embarrassed because I'm not ready, or maybe I feel like I'm in the hospital to begin with because I did something stupid, or whatever that mental world that people live in. But that's a barrier into itself. I mean, how do you overcome something like that?
Yeah, the fierce independence some people have as well. like really wanting
Yeah.
to be in their home,
Right.
and really being like, I've seen it really work for people, and I've seen it really not work for people. Your physician is not the only person. Your physician is not the one calling you saying like, do you have food in the house? That's likely the social worker, a case manager,
Hmm.
a discharge specialist, whatever they call them. Every hospital has a special name for those people who are responsible for that. And this is somebody who tends to either be a nurse or a social worker who's well versed in healthcare. Case managers, I call them kind of like super souped up nurses and social workers. They're nurses who have been at the bedside for years, so they know what is necessary for patient care. But they spend a lot of their time planning and working with insurance, setting up the things you need to be successful outside. These are the people who, if you feel like you can't speak to me, these are the people you should be more comfortable to, share your true needs with.
Hmm.
You have to say, and I don't know how else to say it, but you have to ask. You have to tell us the truth. Like medically, there's very few things you can hide. The things will come out in the lab or an X-ray. Right. Um,
Right.
but I will never know what goes on in your home. I will never know if you need Meals on Wheels. Um,
Hmm.
but I'm also not the person who's going to set that up. A case manager, a social worker, a discharge planning, those people will be the ones to set them up. And they want to do it. And the community wants people to be successful. You would be surprised at the programs different communities have, different councils on agings have, different, you know, um, elder support services throughout the nation have. I've seen everything from like a Walker library, which I thought was just the coolest thing in the world,
Right. Yeah.
where
Yeah.
like,
Yeah.
oh, you may need a walker for a certain amount of time, you check it out and like, or give it back when it's done, or people who donate their walkers, their canes and things like that. I think those are things that are only going to be community based, that the
Hmm.
communities get together and say, like, how can we support each other? And your case manager, your social workers are going to know how to get you those things. Um, I have I have seen unfortunate things happen where people don't tell us what their true needs are.
Yes.
And the best case scenario is a repeated hospitalization. The worst case scenario is somebody gets hurt
Yeah.
or
Yeah.
gets worse.
So I
Um,
just want to go back and say, there, social workers have the role in the hospital. I want to tell listeners as well that in addition, so United Church Homes has our Naviguide program. You can look at naviguide.org and use that as a resource. Your local area agency on aging has these resources available. You should connect with them. And Monique, can you just talk a little bit about the role of a patient advocate in the hospital? Is every hospital required to have a patient advocate, or do only some of them do? And what do they do?
so patient advocacy offices, they may go by different names in different hospitals. They may be called something like patient experience, patient outreach, different things, right? But the role of the patient advocate in the hospital, and yes, every hospital is supposed to have a patient advocacy office or something in that equivalent, is to be that intermediary where you feel like something is not right here. I need help. I need help advocating for myself. I need help navigating the system. And yes, they are employed by the hospital, right? So people sometimes feel like, well, you're not really here for me, you're here for the hospital,
Hmm.
right?
Yeah.
That's something that I hear. But their job, and one of the benefits of them being employed by the hospital, is they know how to navigate the system. They know who's a director of Watch and Watch. They know like where the lost and found for pediatrics is on the second floor. They know those things, and they know what can be done to help resolve the problem. Is everything going to work out 100% the way that people want? Probably not, right? I cannot guarantee that you're going to get the exact thing that you want. But if you feel like I'm not being heard, I feel like I need someone. And a lot of the times they are lay people. So that helps a lot too, because you're speaking to somebody who doesn't have that medical background, but they have that experience background. And they
Hmm.
know like what it feels like when I'm pushing the button and nobody is coming to change me. And, that's something that we hear over and over again is, being toileted is a big experience issue.
Yeah.
And nothing improves without feedback. I encourage people to write letters, to reach out to the patient advocacy offices, to give even the negative feedback, because nothing improves when we don't know that the system isn't working for people. And the things that we've seen improve over time have only been from repeated episodes of feedback and trying and doing things over and over again until we start seeing things being safer and being more pleasant for patients.
Wow. This could be, we could go for hours and hours on this topic, Monique. I just so thankful that you've made the time to be part of this podcast today. And I also want to thank you for putting out a terrific resource for patients and their families. And that's the book, Prescription for Admission. The book offers a comprehensive guide to navigating the hospital system, as well as worksheets and other resources to help plan for your hospital visit, and encourage everyone to check that out. But we can't let you go just yet. We always ask our guests 3 questions about their own personal experience in aging. We always ask permission too. So is it okay if I ask these questions?
Yes, go for it.
Okay. All right. So the very first question I want to ask you is, Monique, when you think about how you've aged, what do you think has changed about you or grown with you that you really like about yourself?
I have become a lot more confident as I've gotten older. And I actually really enjoy that about myself. I think when I was younger, you're trying to find your way in the world and you're figuring things out. And I like now that I know what I like and I know where I stand. And little one-off comments don't send me into that 20-year-old, 22-year-old spiral of being like, what did he really say? And does he like me? And that type of stuff. And it makes me, it's a different way of being now that I feel like I have something to say. So I'm going to say it because I know that I have the understanding and the experience to back the thing that I'm saying. And so I think I've become funnier because I'm more confident, because I don't take things as seriously because I'm not second guessing myself anymore.
That's very, very cool. That's very, very cool. And that actually leads into the second question which is, what has surprised you the most about you as you've aged?
I actually understand my parents a lot more than I thought I would. I understand their journey, why they did things and do things. And it's allowed me to be a lot more patient with them as they get older, because I see where they're coming from. And I understand that. And so I think we all go through a phase where nothing your parent says is right. And everybody sees the exact opposite. And so I think I've really surprised myself by just very naturally coming out of that and into, oh, I see where you're coming from, and being able to have conversations with much more understanding.
Very, very cool. Very, very cool. And our last question is there someone that you've met or been in your life that has set a good example for you in aging? Someone that's inspired you to, as we say at United Church Homes, age with abundance? Yeah.
I actually look at older athletes, and I see that aging doesn't truly have to be. I think we have this narrative that aging means you become this passive thing over time. And you see a lot of very active older athletes nowadays. And it's like, no, a body at rest stays at rest, but a body in motion stays in motion. And I think of that phrase over and over again. And I'm like, wow, that's how I want to age. I am not a runner. If you know me, you know that I hate it. It is an unpleasant experience for even those watching me run, right? But I keep doing it because I know that it's going to pay off. And I see it like down the road, that investing in myself in this age, continuing to be active and not just giving up the ghost and saying like, oh yeah, my knees hurt because I'm getting older. Like, no, keep moving, keep doing the things
Yeah.
that you love.
Keep oiling your joints.
Keep oiling your
doing it.
joints, because, like I said, a body in motion will stay in motion, and I want to stay in motion.
Yeah, and I was actually thinking this exact thing when I was taking a long walk this morning. It's like, yeah, you just need to keep doing it. I just need to remind myself to stretch.
Yeah. Mobility training is big. Mobility training is real big. Yeah.
Absolutely. Well, Monique, it's been such a pleasure talking with you on the show today. And for our listeners, we've been pleased to have Dr. Monique Nugent on the show today. Her book, Prescription for Admission, is available right now. Please check it out at Barnes & Noble, anywhere you get books, including through, I guess, Apple Books and all
those places, Amazon, all those places.
Awesome.
I have a website. You can check it out. It's just my name, drmoniquenugent.com. And I've got some free downloads for people to check out. If you're thinking about purchasing the book, you can download some of the sheets that I've created to do things like learn how to do a family meeting and some of the skills that I teach in the book. I really want people to have these resources. So please check it out.
That's drmoniquenugent.com, and the book again, Prescription for Admission. But most thanks of all to you, our listeners. Thank you for joining us again for this episode of The Art of Aging, which is part of the Abundant Aging podcast series from United Church Homes. And we want to hear from you. What has been your experience in the hospital? What has been the most difficult part of navigating hospitalizations? What tricks do you know for a successful navigation of the hospital? Or what topics do you want to see on this show? Please tell us about it at abundantagingpodcast.com. You can also give us feedback when you visit the Ruth Frost Parker Center at www.unitedchurchhomes.org/Parker-Center. Thank you so much for listening. We'll see you next time.